9 residents here at the village, and I got told that there's a lot of turnover. And apparently recently you used to have a convalescent home, is that what it was called? And that was shut, so now we're in the process of thinking through what are the alternatives. So, tough decision for the community, I think. A good one. How are we doing? You ready to go?
Yeah, I'm going right now.
Oh, you're going right now?
I'm on,
okay.
yeah.
We're on camera. Now everybody be polite. I'm Dwight Moore. I'm a volunteer. Evan's trying to get in there, thanks. Volunteer for End of Life Washington. Just wait a second till we get settled. Thanks for that help.
We need to make this room bigger.
We do.
Oh,
fewer books, more people. Great. So I want to ask you a couple of questions before we start. How many of you have had experience with death? Look around the room. All of us. Okay. How many of you, the deaths that you had experience with, how many of those were what I call bad deaths? Raise your hand. Bad as in pain, anxiety, fear, lack of information from the medical community. So about half of you experienced bad deaths of the deaths that you've been part of. Is that right? Okay. So what we're going to talk about here are the 6 options we have at the time of our death. We probably didn't know that we had 6 choices, but there are. So I'm going to go through those and give you some detail about that. Here's our agenda. We'll talk about those end-of-life options, give you some statistics from the state of Washington, talk about specifically the End-of-Life Option Act, also known as Death with Dignity, which is a law here in our state, as you know. I'm going to pose some moral dilemmas for us to think about toward the end of the presentation, give you some resources, and obviously have time for your questions and maybe some answers, depending on whether I'm smart today or not. So let me start off by asking you, by the way, I'm a psychologist by training in my non-volunteer life. That's what I did. And we do this thing in psychology called a guided imagery. And so what I want you to do is, if you don't mind shutting your eyes or relaxing in some way, I want you to transport yourself to the week of your death. I want you to imagine yourself a week or so or less before the day that you die, and think about, where are you? What's the room look like? What are the colors and the sounds? Who are you with? Is there sound of some sort? Music, traffic, silence? Transport yourself for a moment into that time that we're all facing. And when you get a pretty clear picture of it, smells, sounds, timbre, emotion, go ahead and open your eyes. Okay, volunteers. Give us one image that you have.
My image is in my sewing studio. I would have my hospital bed in there and all my family around with the music that I like playing. That's what I saw.
What kind of music?
I like old music like Perry Como and Frank
Sinatra.
Sinatra.
You can stay. Somebody else.
Jimmy Buffett.
Jimmy Buffett.
Music,
You
yeah.
go, girl. Yeah. Where are you?
I'm in my bedroom with my dog. He's snoring.
He's snoring. On the bed with you or outside the bed?
He's right
there with you. Good. Others? Yes.
Well, I'd like to be in Hawaii on the beach. Probably that wouldn't happen. But somewhere I can hear the ocean and also the hum of the voices of my family. That's what I want.
Yeah.
It's in the forest.
You're in the forest.
It's outside.
Ah. With that wind that goes through the trees? Are you hearing
It's
it?
not, just pleasant.
It's pleasant.
It's pleasant, yes.
calm. Sounds like it's calm and quiet.
I would too. I'd like to be walking on a trail,
On a trail.
and I haven't anticipated very well that I'm dying,
And just
and it just happens.
and die. Wow, great. Okay, I think we get a pretty clear sense here. There's obviously some differences, but there's a calm, there's a solitude, families involved, there's music that we like, we have familiar pets, family spaces. Here's what people, just some of the Journal of the Society on Aging research. Take a look at the parallels between your images and this data. Loved ones, you want to end your pain and discomfort, that the pain and discomfort's managed. I noticed nobody was in a hospital room. I didn't hear anything about tubes and fingers and computers and, okay, catheters. We didn't say anything about all that stuff. Your spiritual needs, however those are defined, are being met. Probably in the solitude you're talking about with the forest images and things like that. And not being a burden on others. That they're participating with you in this transition. Make sense? Okay. Talking about that, sometimes, even if I stand in the middle of the room, no one acknowledges me. This is the elephant in the room. And one of the experiences that I've had, and my wife has, who's a hospice nurse over in Bellingham, is that people just are not yet comfortable talking about death. You want to test this theory, bring it up at dinner tomorrow night and see how people react. Now, you may be one of those folks who've been talking about it for 40 years and say, oh, that's mom again, or that's dad, that's just what they do. But most of us, at least in North America, still don't really have a language for this. And we really don't have a lot of rules, permission of how we go about death. Is that your experience too? So some of you deal directly with that, so you know a lot about this.
Yes.
Those of you who are hospice volunteers, and you two are professional at this. So one of the things that we're trying to do at End of Life Washington is open up the conversation about death. It's just make it more comfortable to talk about it, talk about planning, mass directives, and all those sort of mechanical things that we need to do. Because this is the elephant in the room. And it's getting bigger, gang, because of us, the baby boom generation that's pushing everything forward. And those of you at the top end of that are actually just a little ahead of the baby boom generation. I'm right in the front end of it at 70 years old. And then we got a whole 20 years of people behind me that's just pushing this thing. And the care facilities and the need for unbelievable services are going to overwhelm our systems. So being proactive and thinking about it is part of the deal. Okay. Jennifer Glass out of California died at age 52. I'm doing everything I can to extend my life, but no one has the right to prolong my death. I had the privilege of working in California as part of Compassion and Choices to get the law passed 2 years ago. We did a bunch of lobbying down there. And there's a little glitch right now in terms of a legal fight about it, but we were successful ultimately. Here's a woman who I think says a very important thing about choice. The fundamental belief ethic behind the death with dignity laws is about choice. And choice is a tricky thing when you begin to talk about religious choice and volition, choice, will. So here are the 6 options, 6 ways that you can choose to die. First of all, take all treatment interventions. This would be if you're in a hospital setting or a long-term care facility. Anything that can be done, do it, doc. Including experimental drug trials, interventions, so on and so forth. One of my clients when I talk about my clients, I'm going to keep their names obviously confidential. and disguises. One of my clients in Bellingham, who is eligible for the law and now has the medication to die with dignity, took himself to Swedish hospital last week because of severe pain, and now he's back into a regime of combination treatment and palliative care. So he got off hospice. Actually, he was kicked off hospice because he's now trying to treat himself again. And he's in the medical cycle. So he's gone, actually, interestingly enough, from this bullet back to all treatment intervention. When I talk about this, I hope that I convey that I don't have a bias here about what you choose. I really think the beauty here is about choice, not somebody else's opinion about what you should do. Fair enough? So if I violate that today, tell me, because I don't want to do that. Discontinuing or refusing medical treatment. If you walk out of a hospital and you don't get treatment, you're a bad patient. What is it called? Against doctor's orders? AMA? Against medical advice. There we go, AMA. They have a phrase. But this is basically a choice that you make. One of my clients also has Parkinson's disease, and she oddly is not eligible for the death with dignity law because you can't do a 6-month diagnosis, 6-month terminal diagnosis for Parkinson's. It's a little fuzzier. And so, but she's decided no more medical treatment. Not going to do it. Third is hospice, which is the Hospice of the Northwest and this San Juan Hospice Volunteers, incredible groups. Here comes a bias of mine. The Hospice of Whatcom County, which is a Peace Health Hospice, is also an incredible group of nurses, but they are constrained by the Catholic rules that they're under. So their service is quite different than Hospice of the North or your service. But hospice is a great way to finish one's life. Palliative care, palliative sedation, lots of controversy about what this means simplistically, and I don't want to offend you. Palliative care is the long-term management of health and pain for comfort. Long-term. Palliative sedation is usually very short-term. It's managed most of the time out of a setting, hospital setting or care facility where there's a team, a palliative care team that in consultation with the family figures out a way to help you die relatively quickly. Nurses call it being snowed, which is having enough medication where you're just simply not aware anymore of your surroundings because of either pain or blockage or something like that. That's the sedation. Am I pretty close to those of the actual medical professionals? I'm in the ballpark here. Voluntary stopping eating and drinking. My father, at the age of 94, called me and said, okay, coach, I'm going to stop eating and drinking and you need to come out here, he was in Pennsylvania, and help me die. Usually I think I can kind of like get through this and not, oh well. So, turns out I was more of a linebacker than coach because he was serious about it and he stopped eating and drinking, but there were a lot of well-meaning professionals around him who wanted him to eat, get on IVs, do whatever the next medical treatment was. And my job was to stop them from doing that. In fact, one night, the second night I think he had stopped eating and drinking, a nurse came in with some ice cream. He was notorious for loving ice cream. And sat down next to his bed, got a spoon and put it near his mouth and said, Craig, won't you love some ice cream? And we had long talks, by the way, of his decision. He had it charted, the doctor knew about it, hospice knew about it, everybody knew about it. But I said, excuse me, can we talk in the hall? And so we went out in the hall. She said, look, and he nodded his head, by the way, he wanted the ice cream. But he was 2 days from his death. So I said, he's asked not to eat and drink. He said, when a patient asks for care, we need to give it. We're mandated by law to give it as means. Okay, so she's got an ethical and legal responsibility, apparently, and I had a familiar, a son's responsibility. So I said, how about this? Come on in, you give me the ice cream, and I'll give it to you. So we went back in the room, she gave me the ice cream, and we sat there for about 10 minutes. I was looking at her, and she was looking at me. She said, well, I guess I got others, and then she finally got it, what was happening. So she said, I have other things to do. She got up and left, and I threw it in the trash. This is the linebacker metaphor that I use. And I think it was 2 days later my dad died. He lived 93 and a half beautiful years. And then he had failure to thrive. All of his systems shut down. So he was just ready to go. And he'd been a long time advocate of the Hemlock Society and the death movement. And then the end of life Washington, I'm going to tell you a little bit more about that from a couple of case studies. Any questions about these 6 choices? Am I missing any? Okay. So here's some statistics from Washington. Last year, 115 people in the state of Washington used the medication for death with dignity. Twice that number were eligible for it and had scripts on file in pharmacies, but only half the number of eligible people used them. This, by the way, is a tiny number compared to the number of people who died in the state. Now, I don't have that number in my hands, but it's well less than 1%. The average time to death is about an hour and a half, depending on the medication. I'll tell you a little bit about that. Most of the people that took the medication in the state of Washington were 65 years and older, and the primary diagnosis was some form of cancer. It's much harder, as I said earlier, Parkinson's disease, Lou Gehrig's disease, some of those are just harder to pin down in terms of the criteria, which I'll talk to. 90% were enrolled in hospice, which is fantastic. It's an important, as a volunteer for Death with Dignity, that relationship I have with a hospice nurse is really important because we do different things along that trail. Primary reason for choosing aid in dying was loss of autonomy. Odd. You'd think it'd be pain, you'd think it'd be incapacity, loss of autonomy. And there has not been one instance of abuse in the 8 years of the Washington state law, which of course is important because we want to maintain the law. And Sarah Palin talked about death panels. You may have remembered this during. Who was she vice president candidate for? Was it King? Anyway, I'm sure he's regretting that now. But that was a fear, and I think it's a legitimate fear for us to pay attention to because we don't do death with dignity to people. This is volunteer choice. So those are the local statistics. The Oregon statistics are pretty much parallel to this, interestingly enough. California's just getting up and going. Colorado's just getting up and going. So we'll see what happens in those states. So you've got 6 months to live, but with aggressive treatment, we can help make that seem much longer. Terrible. Huge empathy for this poor schmuck who's sitting on the table. Anyway, so a little levity is okay here. So, basic definition of death with dignity is medical practice which a terminally ill, mentally capable person with a prognosis of 6 months or less to live has the option to request from his or her doctor prescription for medication which they then can choose to self-ingest to die peacefully. The role of the volunteer is to help people navigate this law because there's some steps and road bumps along the way that need to be done right to stay inside the law, but also to make sure people have this choice. And we'll be covering some of that as we go along. But that's the basic definition. Questions about that? Okay, so eligibility, you have to be 18. You have to have terminal illness with 6 months prognosis, also state resident. That's another criteria. By the way, that's an interesting one. I had a client about a month ago who moved here from Colorado and moved in with his daughter. Eligible for the law and all the criteria, except he wasn't a state resident. And what the doctor said is, if you get a lease from your daughter that you're paying her money to stay in her house, then you become eligible. And they did. They drew up a lease, gave it to the doc. She became eligible. getting a driver's license, a voter registration card, having a lease, a regular or a purchase agreement for a home, all make you eligible. And capable, being have the capacity to make medical decisions is important. You have to be compos mentis. You have to be able to understand what's happening to you. And there also needs to be some congruence, some fit between who you were in your previous life and this decision. So usually for people like this, they've talked about this before, their family knows their wishes, they've maybe volunteered as a hospice worker or a nurse in some capacity. So there has to be a fit between one's ability to understand the law and what they've done before. So here's the timeline. As a volunteer, usually somebody calls our office in Seattle. I've got a bunch of brochures right here by you that if you want to pick them up afterward, you can add some numbers. They call the timeline, and the client is referred to us as a volunteer. And what we start to do with them is we make sure that the right things are in place. They need 2 physicians to testify to the 6-month prognosis. First physician is called an attending physician who writes the prescription for the medication. The second one is called a consulting physician who's a backup. The timeline starts with the first request, which is a phone call to the physician saying, I intend to use the death with dignity law, please chart it. That begins the 15-day clock. The reason for the 15-day clock is we don't want impulsive decisions. We don't want people coming into a doc in the box and getting handed the medication. That's one of the ways we separate this law from suicide. And I have a slide on that a little later. So we start there. Then during the next 10, 15 days, we make sure that the 2 doctors are in place, that the patient has seen those doctors, and the doctor's job is to determine or confirm that they have a 6-month terminal illness and that they are mentally stable. If they're not mentally stable, they get referred to a psychologist, and I do this also in another role, to determine their mental stability. A couple stories about that, just to give you an illustration. There was we got determination. The doctor called me and said, I'm not sure this particular patient is eligible. He was in a long-term care facility down in Mount Vernon. So I went to do an assessment, and I asked him who the President of the United States was, and he said, Nixon. And I said, so what day is it? And he said, March? So I didn't need to go on with the assessment. This is a man that didn't have the capacity anymore to make a decision like this. Sometimes people are, another guy I did an assessment with was one of these esoteric, what was that? These guys, conspiracy theorist guy. Okay, well, he had unbelievable theory. But the problem was he was really cogent and very smart, but weird. And you don't get disqualified because you're weird, which is a good thing because some of us in the room are probably weird. So, glad to hear that. So it's the ability to understand the decision and its impact. So we get those things. After 15 days, 14 days, we can make a second request, which is again a call back to the prescribing physician, attending physician. And then there's also a written form which is witnessed by 2 folks saying, yeah, this person has the mental ability to make this decision. Not family members. This is part of the law that litigates against the death penalty or death for granny. Once that's done, the prescription is sent. Get this, it can't be faxed. It has to be hand-delivered or mailed to the pharmacy. The reason for that is you can fake a fax. Somebody could get a script from a doctor's office and write a false prescription. That's the process. So best case scenario timing is that we're looking at about 17 days from start to finish on this. Normally there's a couple of other road bumps along the way, ability for people to get transported to see a doctor. We luckily have a couple of doctors who actually come to the house now. Old, some of us are old enough to remember house calls. Anybody remember house calls? Yeah. Dr. Perry, they did it. We have a couple of docs who are going to do that. And Skype, believe it or not, now has become the method of interviewing. Most people, or at least their grandchildren, have Wi-Fi and Skype, so the grandchildren set up these things. And cute story about this, I had a client who was pretty deaf and lived in this house that had like no electronics, not even a coffee maker. So we transported this gentleman to the library, and the library had to fix up. We got the Skype going and all that stuff. And the doctor was on the other end and interviewing him, asking the questions to determine 6-month diagnosis and eligibility. But because he was deaf, he talked like this! And the door of this cubicle was open, and the people are in the reference tags in the library, and he's talking about dying. I could not figure out a way to deal with it, other than just, that's the way it's going to be. And lots of people learned about the deaf. He was great. So, some things that we talked about. It's voluntary, obviously. The patient must be able to self-administer. So, both of these medications you swallow. If you have a feeding tube, the patient can inject the solution into their feeding tube. But we can't give that. The family can't actually pour it down somebody's throat. It's not injectable like it is in Canada. So these are important pieces of the Washington State criteria. 2 physicians we talked about have to ensure the patient has the capacity and 6-month terminal illness. And then the doctor talks with the patient toward the end of the process to confirm that the individual request does not arise from coercion or pressure from somebody else. Questions about those criteria? So you're not having hot flash. It's really getting warm in this room. That's okay. So, I'm okay to go on, just a couple of other informational pieces. All right. So, medication itself, 1 hour before taking the medication, we have a couple of anti-nausea medications that calm people down and make sure that they don't throw it up an hour from now. It takes usually about an hour for that stuff to work. Okay? And then there are 2 options right now in terms of the medication. One is Seconal, which is a barbiturate, 10 grams of it, which is huge. This, in my mother's day, I remember her taking Seconal to sleep. I can't remember what it was. It was like a half a gram, like a I can't remember what it was. And then the second choice, Seconal, by the way, now costs around $4,000. Yeah, now there's a reason for this. It's manufactured by a European pharmaceutical company, and Europeans do not believe in capital punishment. So Seconal would be fantastic, by the way, for capital punishment. But because the manufacturer doesn't do that, and they don't want to cancel the drug, they put a unreasonable, value statement, unreasonable price on that drug. So the doctors inside End of Life Washington said, wait a minute, there's got to be another way to do this. So over the last couple of years, we've come up with a formulation which we call DDMP2. Has no relevance to anything except the names of the drugs. And here they are. I listed them. Morphine, propranolol, Valium, and digoxin. This is a combination of respiratory inhibitors and cardiac inhibitors. So the first thing that acts on you is the respiratory inhibitors. Is there a way to turn that off?
Yeah, I do.
Thanks, appreciate it. Respiratory inhibitors slows down your respiration rate, and sometimes you die from that. If not, then the cardiac medication, digoxin, kicks in, propranolol kicks in later. Both are equally effective. Everybody has died who has taken these medications. Now, the time it takes to die varies, and there are so many variables in that we're not sure what it is. Okay. What do I say here? It's about 5 minutes after you take the medication, you go into a deep sleep coma, and then the average is about an hour and a half, hour to hour and a half, depending on the medication. Is that more information you needed?
That's good. Very good.
Well, the cost of this is about $600. Family Pharmacy and Anacortes is the closest pharmacy that will compound this. They're a compound pharmacy, and they've been terrific in support of this law. So clients that we've had here on San Juan Island have needed to go into that pharmacy to get it. There is no pharmacy here that does this at this point. Other provisions. Some people worry that, if I do this, isn't it kind of like suicide and I won't get insurance money or something like that? No. Wills, contracts, insurance, annuity policies, are not affected by the person choosing aid in dying. What's listed on your death certificate is the disease that you have. So it's ovarian cancer, it's throat cancer, whatever it is, not death with dignity or suicide. So there's no impact at all on any of the contractual arrangements you have made for your estate. That's reassuring.
Yeah.
And aid in dying is not considered suicide or assisted suicide. And here's the I put this together because I wanted to kind of do a contrast sheet. I'm going to come over here to get out of your way because I'm not blocking. So medical aid in dying is terminal illness, as we've seen, 6-month terminal illness. Suicide, there's no terminal diagnosis here. Most people that die of suicide do have some sort of probably chemical depression. But that's not, I think the current research says only about 1/3 of those people are actually diagnosed with it that commit suicide. Left side of the page, mental capacity is a requirement. For some people that are in the bowels of depression who are contemplating suicide, they are incapable, from a psychiatric standpoint, of making a good decision. My cousin Jason killed himself after 10 years of trying to stay alive. Horrendous depression. And he did everything he could, and then he was done. So he shot himself. He was not capable of making a decision at that point. Patients on the left side want to live. They got family, they got walks in the woods, they got, who was the music, who are you going to listen to?
Jimmy Buffett.
They got more Jimmy Buffett to listen to, right? Suicide patients want to die. The death is gentle with the medication. One of the things that surprised me in all of the deaths that I've attended is how absolutely easy this process is. Some of you have had the opportunity of putting pets down. You've seen that effect. There's no trauma at all. There's an easing into it. Coma comes in about 5 minutes. Sleep is relatively peaceful until your heart and respiration shut down. This is these deaths are violent, usually. Normal grieving after one's death, because there's no guilt, there's a chance to talk this through and work it out as a family. And over here, there's a lot of grief in family life. Is there anything else we could have done? What if we tried this? If I'd only been around him longer. So I like this slide because it helps folks sort of separate the difference between the two approaches. Just a couple more slides, then I'll open the questions. So being proactive, talk to your doc now. Family doctor is the place to start. Oncologist, if you have one, ask them if they would be willing to support you when you ask them to be a prescribing physician or a consulting physician in death with dignity. I switched my primary physician last year because my original one was not able to do it for religious reasons. We had a beautiful talk about it. He was respectful, but he said, I won't be able to do it. So I said, I gotta go get another doctor. And please don't wait till it's too late, because then then we have to scramble to help you get physicians in the volunteer process. I can't list your iPhone as your primary care physician. All right, so any questions before we talk about moral dilemmas?
The primary physician, the first, but then if you need the second, can it be a physician's assistant in that office?
No, it has to be an MD.
Well, that's kind of tricky to get to.
Yeah, it is. Again, the good news is that we've now been around long enough, 8 years here in Washington, is that we can help you find a physician if you're not able to.
For the second one?
For the second one, yes. We've got enough lists now in all of the counties, well, so let me say it, most of the western counties. The eastern folks are still struggling with this because it's a little stronger religious basis, as you know, east of the Cascades. So we're having more trouble finding doctors there. But over here on this side of the mountains, we're good. We can find it back.
Does this need to be in person?
Does the what? The evaluation?
Yes.
No, it could be by Skype.
Okay.
Yeah, or it has to be face to face, quote unquote.
Dwight, because we have Peace Health Hospital here, which is our clinic also, that's where we see
Yeah.
our physicians.
Right.
Can one of those if we have one of those doctors, can that be the consulting doctor because it's a Catholic hospital?
Yeah.
So,
Peace Health is, policy is no. But, now having said that, in the last 2 months, we're starting to see a little weird thing happening. There are a couple of doctors who have agreed to be consulting physicians out of Peace Health.
Oh,
Because they're not hospitalists, they're private doctors who have privileges at the hospital.
oh,
But they run this practice of death with dignity out of their own offices. So it's, right now, it's one of these, we don't talk about it a lot because we don't want to screw it up, frankly. So, but it's encouraging because the fundamental principle still stays the same at Peace Health. But we're seeing a little wiggle room.
so what would you suggest then for everyone here who probably has doctors there? How do you start? Just go find out if one of those doctors
Ask
is,
the docs.
just
Ask
see if your
oncologist or
primary care
either
can be
one.
consulting.
Yes.
Okay.
And when they say no, or if they say no, hopefully you'll be in touch with us. We will start the process of finding you other doctors. We've got a couple of doctors here in San Juan Islands who are quietly taking patients. They worry, and I'm not just specifically here, people like this worry that they're going to get known as the death doctor or something like that. So they'd rather have that be very quiet. Mostly they do their own patients, but sometimes they'll take a referral. We've always been successful at finding doctors. So ask the primary doctor and your oncologists, and then call us. Somebody else got it? Yeah.
I've been trying since September to get this going. It's like an act of God. My oncologist, he works through Peace Health, so he's told me he can't do it.
Right.
And then there's a doctor in Seattle at the Seattle Cancer Care Alliance, and he told me he could do it, but he thinks, he's only seen me twice, but he thinks I have longer than a year to live, or longer than 6 months to live, where my doctor here says, no, I don't.
Right.
So,
Have you called our office?
no, but you know what? I've talked to you on the phone. You've called me.
Oh,
Yeah.
sorry.
There you go. I just recognized your
And
name.
was I helpful?
Well,
Apparently not.
I didn't really talk to you because I was going
Oh.
to talk to this man in Seattle, and I
right.
thought that was going to work out. So I need to get this brochure evidently in God.
Please.
Okay.
Yeah, we'll get you in the system and see where we can work out. Now, if you can't get a doc to give you a 6-month terminal illness, you're not eligible for the law.
Look, my doctor that I normally see does. Your oncologist.
I get it. So what we have to do is find somebody who believes that you have a 6-month terminal illness and is willing to be prescribed.
Yes.
Got it. I'm sorry. Thank you for that. Any other questions? All right, so here's a couple of moral dilemmas. And I'm going to let you look at these, and then if you have an interest in talking about one or two of them, we'll spend a little bit of time doing that, and then I'll take any other questions that you want. So, does this fit with my religion? Oh, here's one that actually frequently happens. What if one child or a spouse doesn't agree with my decision? What about if dementia starts to take over? These are dilemmas that we are facing, we have faced. How do I know when to take the medication? Oh my gosh, this is, on my way back to Anacortes, I'm stopping by and seeing a client who I think will take the medication either tonight or Saturday, but he doesn't know when, and he's still struggling with it. So he asked me on the way back today, after I get across the ferry, could I stop by and be available, and then he'll try to decide. But for about a week, he's been going back and forth about when. And that's a really, really hard decision. And there's no template for an answer on this, by the way. There's just no template. It's holding your hands with the caregiver and trying to talk about it. And then the last one is, why do we, in the law, why do we care about life expectancy? The Canadian law does not require 6-month terminal diagnosis, interestingly enough. It requires that you have a terrible life, which are well, I'm sure there's a medical term for this, but basically the things are horrendous for you, pain, depression, whatever it is, and that you're done. But it doesn't stipulate for 6 months, so we do. Anybody want to speak to any of those?
Yeah, I'm interested in the dementia or aspect, when you've made your decision and then,
Yeah, so the current law says you are then become ineligible for the law if you do not understand the implications of it. 'Cause
even though you've gone ahead
if
in that
change-
6-month
yeah,
period.
That's correct. If that changes. So when I sit with a patient and they're going to take a medication, I have 2 questions to ask them. Do you understand what you're doing? And if they're not able at that, literally at that moment, I cannot give them the medication. We usually mix it up and the patient. So if it changes in that 6 minutes, 6 months, as you were saying, then they're no longer eligible. That's the current status of the law. There are some codicils that are being written by lawyers to try to anticipate this in the future. From a legal standpoint, nobody in this business thinks that those will pass. Because dementia is old and Alzheimer's is so hard to pin down. I mean, it's just stage 1, stage 2, people disagree. It's just very difficult to kind of get whether, I'm forgetful as hell. I got this 3-minute rule when somebody asks me a question about a name, for example. I don't know whether you all experienced this, but I give myself 3 minutes for it to show up somewhere in my brain. Sometimes it's tomorrow. I know, but anyway, you understand what I'm talking about. So it's just difficult to do. That's the current state of it. In our lifetime, I'm going to make this statement, we will not have a way to solve this problem in our lifetimes. I think there will be ultimately because of economic forces. We just simply are not going to be able to afford to keep all of us alive globally. When you think about global population growth.
how about if you went to Canada, is that possible? What are the laws if you're not
Yeah, you can't.
resident of Canada?
Yeah, you have to establish residency, and 6 months that requires. Switzerland, you don't have to establish residency. There's a program in Switzerland for, I think it's about $10,000. After you fly there, you can dive taking. Good question. Yes.
So what if one child walks? How do you handle them?
So my psychology professors would say, you get paid to give these answers, but so I don't get paid for this, but talk is essential, and decisions to take medication have been delayed for weeks because people aren't going to talk. The way the decision tree usually works on this is that the 2 parents decide whether they're going to include that particular kid who you think is going to balk at all. So most of those decisions are, we're not going to tell Jill about this. We'll tell John and we'll tell Fred, but Jill's not going to be included. She'll know that mom's been sick, but we'll do this and then tell her that you died. So that's the first step, and I would say 60% of the parents take that approach. Now, with a spouse, you can't take that approach. You've got another dilemma. So that approach then usually is to get a couple of the kids and lots of family discussions about what the right thing is. And usually there's a kind of a silence, agreed to silence on the part of the person who disagrees with the decision. I understand, I disagree, but I'm not going to fight you. If this is your decision, I'll be here. I had a spouse who couldn't be in the room. That was her, so I can't do it. She played the harp. She went out in the living room and played the harp while I helped him die. And then after he died, she was able to come back in, but she couldn't physically be present. Some people aren't able to mix the medication. You can ask me to do it. It's a bit of a call, mixing medication for your husband. There are no magic answers to this one. Sorry, I really wish I had them.
My question's right along this line. I recently assisted at a case where the spouse was not for it up to the very end. But because I came in later to the case, I wasn't present for weeks, it was just a few days. what I wanted to know is, do you provide any counseling, or they didn't really have anybody up ahead come and talk to them. The wife was definitely, she was going to do it, or the ones, the person was, but is there counseling for?
Yes, absolutely. So our hope is we get involved in the case as soon as we can.
Okay.
So normally I'm probably in touch with folks on an average of 2 to 3 months. And after a first visit, we figure this stuff out. And then I become a counselor around that particular problem.
Good.
Coordinated with hospice care if they're on hospice, because our experience is the between the chaplains and the social workers are fabulous at this also. So and we help these folks work this out. And I was trained in family dynamics in my PhD program, so I walk in the room and I get what's going on. Out in Walla Walla was a case where there were 6 kids, and every one of them wanted to do something different at this death. One wanted to bake, the other one wanted to vacuum the house, the third one was taking care of the dogs, one was willing to be in the room with a mom in this case, and it was amazing to watch that, and they felt guilty about that because they all felt they should be huddled around the bedside. And I could relieve some of that tension. That's not necessarily each of you contributing in the ways that you're most comfortable. Good question. We're about at the end here. Any other questions? Okay, so here's some resources. These are also in the book. So end of life, here's the website, of course. Everything has to have a website. There's an actual telephone number where you can talk to a human being. And this is that's my number if you want to call me. Thank you very much.
Thank you.
I got time before the ferry goes, so I'll stick around if you have any other questions.
So I have a question. 2 questions, 2 comments really. Comment 1, science is working on a way to either arrest or reverse the aging process. And I'd like to stick around for that, if possible. And comment 2, if I have to go, I want to be a suicide bomber, and I'll take a trip to Washington, D.C. and where I'll go.
I can't comment on the video.
Right.
Edit
Thank you.
video if I were you.
Thank you very much.
Okay, folks.